So if you've been to, like, a dinner party recently or, just hanging out, you've probably heard someone confidently bring up the ancient Roman vomitorium.
Oh, yeah. The classic trivia fact.
Right. People just love trotting this out. The whole story goes that the Romans were so excessively decadent and so obsessed with banqueting that they built these dedicated rooms in their villas.
Right, where guests could just excuse themselves between courses.
Exactly. Like they'd go purge everything they just ate and then just casually return to the table to start all over again.
Yeah, it's a really persistent myth.
And it's constantly used to, I don't know, sort of dismiss binging and purging as some kind of normalized ancient cultural tradition of luxury. Like, oh, the Romans did it.
Right. But it is entirely false, like completely made up.
Wait, really? The whole thing?
The whole thing. A vomitorium has absolutely zero to do with banqueting or eating or purging. I mean, it's literally just a standard architectural term.
Okay, so what is it actually?
It refers to the massive passageways built beneath the tiers of seats in Roman stadiums, amphitheaters. They were designed for crowd control, allowing tens of thousands of spectators to exit quickly.
Oh, so essentially vomiting the crowd out into the streets.
Exactly. But we eagerly cling to this fake history, because it's much more comfortable to dismiss disordered eating as this decadent, ancient luxury than to face the brutal reality of what it actually is.
Yeah, which brings us to our mission for you on this deep dive. Because today we are opening up a massive stack of medical history, psychiatric manuals, and psychological research to just completely dismantle those comfortable myths.
It is so needed.
Yeah. We are looking squarely at bulimia nervosa. We're focusing on the biological and the psychological mechanics of the binge and purge cycle, like how the body actually breaks down under the strain and why this illness is so wildly, dangerously misunderstood.
And, to understand those modern misconceptions, we really have to look at how recently this was even defined in the first place.
Right, because it wasn't a formal medical thing until when?
Not until 1979.
Wow. That is incredibly recent.
It is. A British psychiatrist named Gerald Russell published a paper in Psychological Medicine. And he gave it a rather striking title. He called it Bulimia Nervosa, an ominous variant of anorexia nervosa.
Okay, wait. The word ominous really stands out there.
Yeah.
Yeah, that sounds more like a Victorian ghost story than a clinical psychiatric diagnosis.
It really does. But if you read through Russell's original clinical notes, you totally see why he chose that specific word.
Why?
Well, he was treating these severely emaciated patients for anorexia, but he kept encountering this subgroup of patients who looked, honestly, physically healthy.
Like they were at a normal weight.
Right. Normal weight, sometimes even slightly overweight. Yet their internal psychological architecture was completely identical to his starving patients.
Oh, wow. So the same fears.
Exactly. Their entire sense of self-worth was exclusively tethered to their body shape and just this absolute terror of fatness.
And that terror drove them to, what, cycles of secret binge eating?
Yeah. Secret binges, followed by self-induced vomiting or, laxative abuse to try and undo the caloric intake. And Russell called it ominous specifically because of the invisibility.
Right, because you can't see it.
Exactly. A severely anorexic body broadcasts its distress to everyone in the room. But a trip to the bathroom after dinner, that goes completely unnoticed.
Right.
So this new variant was chronic, the relapse rates were significantly higher, and the patients could hide their behaviors for decades, all while their internal organs just quietly absorbed the damage.
God, that is terrifying.
Mm-hmm.
But pinning down exactly what constitutes that damage, and I guess who actually qualifies for help, has been historically pretty messy.
Pretty messy.
Because watching the DSM, the diagnostic manual used by psychiatry, watching them try to define bulimia over the years is honestly like watching a fickle homeowners association constantly change the neighborhood zoning laws.
That is a perfect way to describe it.
Right. Like in 1980, the rules were super loose. It was just recurrent binge eating and feeling bad about it. And then by 1994, they required the cycle to happen at least twice a week for 3 months. And they split it into purging and non-purging subtypes.
Right. And then, in 2013, the manual shifted the borders again. They dropped the subtypes entirely, and they actually cut the required frequency threshold in half.
Down to just once a week.
Yes.
Which, that seems like a massive administrative border shift. Suddenly you have millions of people who didn't qualify for a diagnosis on Tuesday, and they wake up on Wednesday with a formal psychiatric condition.
Yeah. But that administrative shift had profound clinical implications because extensive research had finally demonstrated that a patient trapped in this cycle once a week They suffered the exact same psychological severity and chronic physical risk as someone engaging in it twice a week.
Oh, I see. They needed the intervention just as badly.
Exactly. By lowering that threshold, the psychiatric community moved a massive population out of this vague, catch-all, not otherwise specified category.
Right. And a formal name diagnosis is basically the key that unlocks the healthcare system.
It is. It dictates whether your insurance will cover an inpatient stay or if you even get access to targeted, evidence-based therapies.
And, accessing that therapy requires dismantling what is probably the single biggest misunderstanding the public holds about this illness.
The willpower myth.
Yes, the willpower myth.
Okay.
People tend to view bulimia as a failure of appetite control. They assume someone just simply loves food too much, gives in to cravings, and then violently overcorrects out of pure vanity.
Right, which is just fundamentally wrong.
Completely. Because if you look at the dominant explanatory model, this was developed by British psychologist Christopher Fairbairn, the binge is actually stage 3 of a 4-stage cognitive behavioral loop.
Yes.
The disorder doesn't start with food at all. It starts entirely in the mind.
Right, and Fairbairn's model, it really fundamentally reorients how we view the whole illness. Bulimia is not a disorder of appetite. It is a disorder of extreme restraint.
Restraint. Okay, walk us through the stages.
So stage 1 is the over-evaluation of shape and weight. This is where a person's entire identity is held hostage by the scale.
Right.
Then stage 2 is where the actual mechanics begin. Strict dietary restraint.
Like hardcore dieting.
Extreme. The person establishes rigid, frankly biologically impossible food rules. They ban entire macronutrients, they set these draconian calorie ceilings, and they literally attempt to starve themselves into submission.
And, think about every time you've tried a restrictive diet. You suddenly find yourself aggressively obsessing over, like, a stale donut in the office break room.
Exactly.
Now, multiply that biological panic by 100, and you start to understand the mechanical engine here. Which brings us to stage 3, right?
Yes. Disinhibition and the binge.
Because the dietary rules are biologically unsustainable.
Totally unsustainable. So a trigger hits. Maybe it's a stressful day at work, or maybe it's just taking one single bite of so-called forbidden food and deciding the whole day is ruined.
And the restraint just snaps.
It snaps. But the resulting binge isn't a lack of willpower.
Right, it's like holding your breath underwater. When you finally break the surface and gasp desperately for air, nobody accuses you of lacking respiratory discipline.
No, of course not.
Your biology just simply took over.
And the historical evidence for that biological override is incredibly robust. Consider the Minnesota starvation experiment.
Oh, this is fascinating. Ansel Keys. Right?
Yes, Ansel Keys, back in 1944 and 1945. Researchers took healthy men. These were conscientious objectors to World War II, and crucially, they had zero psychiatric history.
No history of eating disorders or anything.
None. And they subjected them to prolonged, severe caloric restriction.
To see what starvation does to the body.
Exactly. And once the starvation phase ended and the refeeding began, these previously completely healthy men exhibited totally uncontrollable binge eating.
Wow.
They became intensely obsessed with food, hoarding it, and eating to the point of literal physical illness. The experiment proved that extreme dietary restriction mechanically manufactures binge eating behaviors.
Regardless of a person's underlying psychology.
Right, it's biological.
It's just the inevitable physiological output of a deprived system.
Mm-hmm.
But with bulimia, that biological gasp for air triggers stage 4, which is compensation and just profound shame.
Yes.
The binge creates this sheer panic about weight gain, which prompts the purging.
Right.
And the real tragedy of the loop is that the physical act of purging temporarily relieves that anxiety,
Right.
which paradoxically resets the person's resolve to restrict even harder the next day. And so the engine just restarts at stage 2.
And the shame that drives that engine forces the patient into absolute, complete secrecy.
Yeah. Princess Diana actually spoke about this secrecy in her groundbreaking 1995 BBC Panorama interview.
That was such a huge moment.
It really was. She looked right at the camera and called bulimia a secret disease. She explained that she used it as a coping mechanism when her self-esteem was just at a low ebb. But, I wonder if calling it a secret disease born of emotional pain accidentally romanticizes it a little bit.
How do you mean?
Like, does it make it sound like this tragic, delicate, aristocratic flaw rather than a brutal, messy biological loop that literally destroys the body.
Yeah, it definitely runs the risk of romanticizing the behavior, especially if we only focus on the emotional pain and we ignore the catastrophic physiological toll,
Right.
because the secrecy allows the physical damage to just compound in the dark. Many patients, and honestly, certainly the general public, operate under this total delusion that purging is a mathematical undo button.
Right. The assumption is that vomiting simply cancels out the binge. But the human digestive system doesn't work like an Excel spreadsheet.
Far from it. A really significant percentage of the calories and sugars from a binge are absorbed into the bloodstream before purging even occurs.
Oh, really?
Oh, yeah. But honestly, the far greater danger is the mechanical trauma. I mean, eating disorders carry the highest mortality rate of any psychiatric illness.
The highest.
The highest. And with bulimia, the threat of sudden death is very acute. The continuous cycle of purging violently depletes the body's electrolytes, particularly potassium.
And potassium is vital for the heart.
Right. It is the critical ion that resets the heart's electrical grid after every single beat. So when potassium levels crash, the heart's electrical system literally misfires. It gets stuck, which leads to cardiac arrhythmia and sudden cardiac arrest.
Which just proves this has absolutely nothing to do with how much a person weighs.
Nothing at all.
Like, there's a tragic example from the historical sources here. The singer Karen Carpenter in 1983.
Yes.
While the public memory associates her strictly with anorexia, her actual medical reality involved severe chronic abuse of ipecac syrup to induce vomiting. And ipecac contains a chemical compound called emetine.
Right, and emetine is highly cardiotoxic. With repeated use, it literally degrades the myocardial tissue, like the actual muscle fibers of the heart itself.
It destroys the heart muscle.
Exactly. The drug accumulates in the tissue over time. And Karen Carpenter's death was attributed to heart failure directly caused by this chemical degradation. It is a chilling reminder that the compensatory behaviors of bulimia can be independently fatal, completely regardless of the number on the scale.
And because the scale often looks normal, families and primary care doctors, they just miss the severity of the illness for years. But the body always leaves physical clues.
It always does.
Often it's actually a dentist who spots the disease first.
Yes.
Because they are trained to look for something called paramolysis, which is this severe erosion of the dental enamel on the tongue-side surface of the upper front teeth.
Right.
It's the direct result of constant exposure to highly acidic stomach contents.
Medical professionals also screen for Russell's sign named after Gerald Russell, who we talked about earlier.
The 1979 paper guy?
That's the one. These are calluses or deep abrasions on the back of the knuckles. They're caused by the repeated friction of the skin scraping against the incisors during self-induced vomiting.
Wow.
And internally, chronic laxative abuse leads to a condition called cathartic colon.
What is that?
So the constant flood of stimulant laxatives actually damages the myenteric plexus, which is the nerve supply of the intestinal tract.
Okay.
The enteric nervous system gets downregulated to the point where the colon literally becomes an inert tube. It becomes completely incapable of natural peristalsis without chemical stimulation.
So it just stops working on its own.
Exactly.
The physical reality is just devastating. And knowing all of this, looking at how the body breaks down, I really have to challenge how modern diagnostic borders are drawn.
It's highly debated.
Because the current rules dictate that the only formal distinguishing line between a diagnosis of bulimia nervosa and the binge-purge subtype of anorexia is the patient's current body weight.
Yes, that is the current standard.
I mean, that seems like a deeply flawed, incredibly arbitrary way to classify a complex psychiatric illness. If the cognitive terror is exactly the same and the physical behaviors are identical, why rename the disease just because a patient gains or loses a few pounds?
You're not alone in thinking that. It is one of the most fiercely debated issues in psychiatric taxonomy right now.
I can imagine.
Critics argue that a patient's weight is honestly the least informative metric regarding their psychological state or their acute medical risks.
Right.
Under the current DSM framework, a severely ill, low-weight patient diagnosed with binge-purge anorexia could gain just enough weight to cross an arbitrary BMI threshold.
And then what?
And their diagnosis would just flip to bulimia nervosa overnight.
Even though nothing changed.
Right. Their fears haven't changed, their dangerous behaviors haven't changed, but their medical chart does. It really exposes the fragility of trying to neatly box up human pathology.
And those boxes are blurring in other directions, too. Like there's binge eating disorder or beta, where patients experience the biological and psychological binge, but they don't engage in the compensatory purging.
Right. And for decades, BED went entirely underrecognized because clinicians operated on this terrible bias that eating disorders only affected thin people.
Right, which we know is entirely false.
Right.
But what's really terrifying to me is how these specific methods of purging are mutating today. I mean, how do hyperspecific variants spread so rapidly now compared to, say, the 1980s?
Well, they spread because the cultural accelerants are now algorithmic, and they are constant.
Social media.
Yes, we are seeing terrifying modern variants like diabulimia.
Diabulimia.
Yeah, this occurs when people with type 1 diabetes deliberately underdose or entirely skip their life-saving insulin injection.
Like, why would they do that?
Because without insulin, the body cannot process glucose, so the cells literally starve in a sea of blood sugar, and the body flushes the excess calories out through the urine.
Oh my God.
It is essentially weaponizing a chronic autoimmune disease as a purging method, and it rapidly leads to diabetic ketoacidosis, where the blood becomes dangerously acidic. It carries a massively elevated mortality risk.
That is horrific, and the blueprints for these lethal methods are just sitting in our pockets. Like, social media has completely replaced the print magazines of the 90s as the primary engine for appearance comparison.
Totally.
But a magazine is static. Social media is reactive. The algorithms are specifically in tune to flood a vulnerable user's feed with prosemia, which is pro-eating disorder content, the literal second they linger on a body-checking video.
Right.
It just creates this normalized echo chamber for the secrecy.
And to understand the sheer biological power of that media exposure, we have to look at researcher Ann Becker's landmark Fiji study.
Oh, this one is unbelievable.
It is one of the most important natural experiments in modern psychology. So before 1995, the islands of Fiji had no broadcast television at all, and the local culture celebrated a robust, much larger body ideal.
And eating disorders were what, rare?
They were virtually non-existent. But shortly after Western television and its ultra-thin ideals were introduced to the islands, Becker observed this massive, rapid spike in disordered eating attitudes and self-induced purging among adolescent girls.
So they get TV, and within just a few years.
Yes.
That just proves that this isn't just about an individual having low self-esteem. It demonstrates psychological contagion. Introducing a toxic cultural ideal actually shifts biology and behavior on a societal level in a matter of, 3 years.
It really completely reframes eating disorders, not as individual failings or vanity, but as these profound vulnerabilities to aggressive cultural messaging.
So what does this all mean for you as you're listening? When you take a step back from the dinner party myths, the vomitorium and the dismissive stereotypes, the picture of bulimia nervosa is entirely different.
Completely different.
It is a lethal, self-perpetuating mechanical loop of dietary restraint, biological panic, and profound psychological shame. It hides in plain sight behind normal body weights.
All right.
It demands that we look closer, that we challenge our assumptions about willpower, and that we recognize the subtle signs like the dental erosion or the calloused knuckles that often reveal the physiological crisis long before the person is ever ready to speak about it.
And, as we look to the future of treatment, there's a really fascinating anomaly in modern medicine that we want to leave you with today.
Yeah, this part blew my mind.
So, Christopher Fairbairn's cognitive behavioral therapy, that remains the gold standard for psychological treatment. But when it comes to psychopharmacology, there is currently only one FDA-approved medication specifically for an eating disorder.
And it's an antidepressant, right?
Yes, it's the antidepressant fluoxetine, which is better known as Prozac.
But the clinical dosage for bulimia is wildly different than for depression.
Exactly. Fluoxetine is approved for bulimia at a dosage of 60 milligrams per day.
60 milligrams.
Yeah. That is significantly higher than the standard starting dose used to treat major depressive disorder.
Right.
And it forces researchers to ask these really fundamental questions about the neurochemistry of the disease. Like, why does a restraint-fueled eating disorder require such a massive chemical intervention compared to standard depression?
Which suggests what?
It suggests that the neurobiological engine of bulimia operates on a completely different frequency.
It reminds us that to treat these invisible illnesses, medicine has to look far beyond just, handing out standard treatments. We have to address the specific, unique engine of the disorder.
Absolutely.
We started today talking about the myth of the Roman vomitorium, this whole idea of hidden rooms built for casual indulgence. But the reality is that the only hidden rooms in this story are the psychological prisons of isolation and impossible dietary rules that people build inside their own minds.
That's incredibly well said.
And unlike a physical building, you can't just walk out.
Yeah.
You have to dismantle the architecture, one impossible rule at a time. Thank you for joining us on this deep dive. Take care.